Hi, this is Bud Pate. We're happy to bring you the following conversation between Lisa Eddy and Fernando Trevino regarding multi-patient metered dose inhalers. This issue is coming up across the country, as you hear Lisa talk about, primarily due to the increased number of respiratory treatments that are necessary given the COVID-19 and the somewhat suspect or alarmingly low supply of inhaler medications. So some people are considering this process, and you'll hear a good discussion of that. But what we're really pointing you towards is what you see on your screen here, or can be available for download at our website, and that's a risk assessment. Whenever you're talking about doing this, putting multiple patients on a ventilator, staffing, people who would otherwise not be qualified to do something with extra training and oversight, those sorts of things usually call for a risk assessment to satisfy accreditation and governmental oversight when all of this is done and behind us. And so we're providing this discussion as a context for this written risk assessment, and we'll provide this. You will see that in the risk assessment we talk about what the issue is. First, we analyze what the regulations say. Then we review quality risk management data, talk about operational considerations, and then we take a position so that the position of the organization is backed up by a regulatory analysis and quality and safety analysis and a review of the literature. And so here's the literature review that is associated with this. So feel free to use this not just for this issue, but as you think about other sorts of things that you're doing to cope with the pandemic. So with that, let me give the mic over to Lisa and Fernando.
Welcome everybody to the Greeley Pipeline channel. We're going to be talking today about COVID-19 use of respiratory therapy medications and what some of our clients have been talking to us about in the industry, which is basically using a single dose, multi-dose inhaler canister for multiple patients. And so because we thought this was an interesting topic and something that we're encouraging our clients to do a risk assessment about, I have with me here today Fernando Trevino, who's Greeley's compliance consultant, and one of them, and very busy, by the way, and a respiratory therapist. So I have a few questions for Fernando related to this respiratory therapy treatment. So Fernando, welcome. I just wanted to ask you, first of all, what is the benefit of switching, or the pros cons of switching from nebulizer treatments to multi-dose inhaler treatments, meaning one canister for multiple patients?
Right, yes, there is a benefit. And the benefits are that if you use a metered dose inhaler, you cut down on time. It's delivered a lot quicker. The administration of the medication is delivered a lot quicker. Over a nebulizer, that's going to take about 8 to 10 minutes, to where with an MDI, it's going to take an inhalation. So as far as that's concerned, the whole practice becomes a lot more efficient.
Okay, and then as I understand it, when there's a nebulizer treatment, there are respiratory droplets that sort of hang in the air during and after the treatment. Is that correct?
Yes, it is. When you're administering it through a nebulizer treatment, you're just inhaling and exhaling outside of a little port. So all that is going out into the ambient air. And yeah, there's risk there.
Okay. And then also, I was reading, there's some information about this on the web. ISMP had an article in 2009, and then they just published one, I believe, today. They discussed in 2009 the use of a single canister for multiple patients, and they give the risks and benefits. And then today they discussed revisiting that issue and again provide the risks and benefits. And one of the things that is of concern to most hospitals is conserving that respiratory therapy medication. So Fernando, with the metered dose inhalers, how is that conserving it versus the nebulizer treatment?
Well, if if you just look at the average stay per patient, and if they're on an MDI and they have their own meter dose inhaler, they're only going to consume 11 to 13% of it, which leaves around 87% to be thrown away if the patient doesn't take it home with them. So what you can do is, by using these spacers, you can now use this meter dose inhaler with multiple patients. As long as the important thing there though is that you're practicing proper infection control. But what this meter dose, what the spacer does, I'm sorry, is that you're not connecting the actual meter dose inhaler to the patient's mouth. You're administering it through this spacer. That way, you wipe it down, and then you can use it from patient to patient to patient. And that's the advantage of using these spacers, that now you have something that you can use on several patients instead of just one.
So are the spacers, so the meter dose inhaler stays with the provider or the respiratory therapist, or it goes back into the Pyxis or whatever. The spacer, obviously after being cleaned, the spacers are disposable and they stay with the patient until the patient's discharged from their location of care, right?
Yes, the spacer stays with the patient, and the meter dose inhaler can either go to the Pyxis or stay with the practitioner, whichever practice it is that the hospital chooses.
Okay, and then I was reading that not only in the operating room environment, so anesthesia providers, rather than using a nebulizer treatment because again of the respiratory droplets and whatnot, and the time, they were going to MDIs, multiple use MDIs, multiple patient use MDIs. And also I can see this happening in the PACU. Can you see it happening in other areas?
Oh yes, especially right now. Again, as the practitioners become more and more busy with all the diseases that are going on out there, you're going to need to make better use of your time. And the use of a meter dose inhaler just cuts so much time on the delivery of this medication that it's really a good thing for the hospital to be practicing. Now, again, I can't stress enough, as long as they're practicing good infection control processes.
So Fernando, when you talk about a spacer, because that again provides a level of protection from the patient's mouth to the canister, and then that
Right.
spacer gets disconnected and stays with the patient, then you wipe down the nozzle part of the canister, the end piece where the spacer fits on, and the canister itself, right?
Yes, it's just like administering an injection, for example. You need to wipe down the actual MDI and the mouthpiece, and then both ends of the canister.
Okay, and then one of the things that we're going to encourage clients to do is to create a risk assessment where they really look at some issues related to moving to this practice of using a single multi-dose inhaler for multiple patients. And I'm just going to run through, Fernando, the things that I can think of for risk assessment. Then I'm going to ask you if I've covered everything, because I'm not actually a respiratory therapist. I'm just a nurse, and I'm not absolutely certain. So what I would recommend to a client would be, and we do have a sample risk assessment that we will make available to folks, would be the very first thing is to look at the regulations. Well, first of all, why are we doing this? What is the point of doing this? What's bringing this to the forefront? Then I would look at the regulations. Is there anything from Joint Commission, CMS, the state agency, any of the other regulatory accrediting agencies? To my knowledge, no, there's nothing that addresses an MDI. There are lots of requirements related to medication, but none of those address MDI in any way. Infection control, however, we want to be very careful that we are looking at infection control, sanitation of the various pieces of the MDI, the spacer, the nozzle, all those things that go from patient to provider. We have a very good infection control discussion of that, what needs to be cleaned and how, and I believe it's with an alcohol wipe of all that area, but I'm not absolutely certain. I'm going to ask you to validate that. And then we're going to want to look at what are really all the pieces of equipment. So far, to my knowledge, it's the multi-dose inhaler itself, the canister, the spacer, and the little mouthpiece that fits onto the spacer part. And then we would want to make sure that for nursing staff that haven't used an MDI with a spacer, we want to make sure if we're going to move to, say, you said emergency department, if they are using in the ED or maybe a PACU nurse or whatever, that if they're going to go to that, they understand two things. One, how to use it, how to deliver the medication. Are they competent? And two, how to do the sanitation of the pieces of the multi-dose inhaler and the spacer. And then we would want to make sure that there's the education to the staff, when to use it, why we're using it, are they competent, and then move all that information up through likely the infection control committee. I would want to make sure, and I'll ask you this, Fernando, I would want to take this to my respiratory therapy department first to get their okay with it, find out from their perspective what was needed, and then go forward to infection control. What do you think?
Absolutely. All those processes and all those steps that you just mentioned are going to be a necessary part of making sure that this new process is successful and is doing what it's set out to be. But again, you just need to have a good, solid infection control process, have all the necessary people involved. And again, if there's any questions out there and stuff, there's just plenty of sites on the web that folks can go to, looking up aero chambers, MDIs, there's a lot of information out there that you can use. But yes, you're absolutely right as far as having the right people being a part of this.
I'm glad you mentioned that, Fernando, because there's, as I think I mentioned, there's a new ISMP medication safety alert about this particular topic that came out today, which is the 26th of March, and I believe it's available to folks. The other thing I wanted to just make sure that we're clear on, ISMP and other agencies talk about perhaps with COVID-19 patients or severely immunocompromised patients that they're going to be in isolation, the COVID-19 patients likely, that we may not want to use a multi-dose inhaler, but they don't. The readings that I've been looking at, the articles, don't say you cannot. They say you want to consider whether you should or not, and they leave that up to the facility. And then they have talked about, at the very least, segregating the multi-dose inhaler canisters when they're not in use, so that we further reduce, for these types of patients, so that we further reduce the risk of contamination. What do you think about that from a isolated patient standpoint?
That too is correct. I'll say this, using a multi-meter dose inhaler, if you're going to use it on more patients, usually if the patient is in isolation or has some kind of disease process that requires that, it's really not good practice to do it. Again, it's up to your risk assessment and how good a training and the people that are performing it are. But yeah, you want to be very, very careful, if you're going to practice that.
Okay, so just to kind of summarize and wrap it up, we do have a risk assessment sample for listeners to take a look at. We are not recommending one way or another. We're just saying that this is coming to us from multiple avenues from our clients and other healthcare organizations as they deal with shortages in relationship to COVID-19, particularly the shortage of respiratory therapy medications, albuterol, and so forth. So we want to provide an avenue for people to really do a thorough risk assessment and determine risk versus benefit, and take that up through your channels, get that documented. Make sure, if you're going to do this, I would absolutely go to respiratory therapy, make sure you've got their input, take it to infection control. I would also want to run it by my P&T committee, and if we have to do something quickly, at least get the P&T committee chairman sign off and the infection control chairman sign off, and then go ahead and, when you have time, take it up through the normal channels. But I would make sure that we did a thorough risk assessment first, get that on the books, and then go forward. So that includes today's topic. Fernando, is there anything else you want to add?
No, I think we touched on the main points, so thanks for having me, but yeah.
Okay, well, thank you, everybody, and we encourage you to go to, for further information about what Greeley is doing to prepare our clients and help our clients in the COVID-19 environment. Please go to greeley.com. That's GREELEY.com. Thank you.